Welcome to my presentation of diagnosis of detrusor contraction strength and detrusor underactivity in female patients. I have no disclosures. Urinary tract dysfunction in women is common, but specific incidence of voiding dysfunction is relatively low in women compared to men. But detrusor underactive voiding contraction is relevant in both sexes. The quantification of detrusor contraction in men is not very controversial, but in women it is slightly more difficult. Determining the detrusor force at such a high speed with high flow rates is not easy and less straightforward, and that makes us researching this. What we wanted is to use the standard parameters for voiding dysfunction and compare those with outcome of the voiding, which is effective voiding. The other part of the study is that some research studies suggest an adjustment for the BCI for women, and that is a change suggested from 5 times Qmax to 1 time Qmax, and that would better associate with stop flow testing. So we tested first whether pressure flow study analysis parameters associated with ineffective voiding, and also whether alternative BCI 1 time Qmax, or as the other alternative just to try out 10 times Qmax are better predictors of ineffective voiding in women. We had a set of data, and we excluded the women with very large or very small volumes voided and very large post-void residuals, and then we had 1100 women with a mean age of 50 years and a mean voided volume of 360 mL with a mean PVR of 41. That PVR result was of course very skewed with a median of 0 and 66% voided without post-void residual. Here are the results in a graph, pressure flow results. You see on the x-axis the Qmax and the predated Qmax on the x-axis and Qmax on the y-axis, and the ineffective voiders with a black dot. PVR correlated weakly with age, and some had bladder outflow obstruction, a small percentage, but 35% had detrusor underactivity as assessed with BCI or WF max. Post-void residual correlated negatively with contraction, and post-void residual correlated negatively weakly with outflow obstruction. The patients with a voiding efficacy of less than 80% are marked in this graph, and they present in the left lower low flow, low pressure area, although the majority of the patients in this area had 66 of these had effective voiding. So they had effective voiding instead of being diagnosed underactive detrusor in the graph and with the parameters. Bladder outflow obstruction is rare, and especially almost all of these had post-void residual. So women with ineffective voiding were older, voided less, and had lower Qmax. What about adapting BCI to 1 or to 10 times Qmax instead of 5 times? So here is the ROC curve of the original parameters, and it shows that the WF max, Qmax, and BCI, the original BCI, correlate very well with PVR. However, adapting those the BCI to BCI with a key of adapting factor of 1 does not help predicting PVR, and adapting this to 10 is similar, gives a similar result than 5. So contraction emptying velocity, so Qmax should be in the index, otherwise then it does not predict PVR as well as with a high amount of Qmax, a higher weight of Qmax in the index. So what have we seen? The data shows clinical epidemiology. 66% of referred women void without post-void residual. Underactive detrusor contraction is prevalent with and without post-void residual. Bladder outflow obstruction is rare. Contraction parameters that include flow rate and that are the original contraction flow rate parameters show a good association with ineffective voiding, and shortening speed of contraction is probably more relevant to empty completely than maximum of force, and that is contrasting in women different from men. So both are relevant to diagnose underactive bladder syndrome. However, we do not know how to predict the ability to void after obstructing surgery. So adapting pressure flow contractility parameters towards maximum of contraction force is not helpful to predict inefficient voiding, but may help to predict outlet obstruction intervention. And we have described a large cohort of women. Many women with detrusor underactivity have effective but slower micturition, and the effectiveness of female voiding is strongly associated with the speed of contraction. BCI has a fair sensitivity to associate with reduced voiding percentage, but a low specificity. I thank you for joining me in this work.